Good afternoon and assalamu alaikum. Once again, welcome back to hematology lecture series. Last in this hematology lectures mm, is on coagulation disorder. So learning outcome for this topic is you should be briefly knowing about what is coagulation and bleeding disorders. We have already introduced you the bleeding disorder, so more on coagulation disorders now. I've done a brief introduction. You should be able to describe and classify the coagulation disorder, elaborates the inherited coagulation disorders, including their epidemiology, inheritance, pathogenesis, clinical feature, lab diagnosis, and then the acquired coagulation disorder, mainly the DIC, disseminated intravascular coagulation. So for this is an important topic, exam point of view and clinical point of view. Emergencies are also in this. So you need to keep your concepts very clear. So be clear with this. This morning we already discussed about hemostasis and its process physiology. You already know there are four phases: vascular, platelet, coagulation, and fibrinolytic system. Here we are more concerned with coagulation cascades. We have seen this morning about the pendulum of balance of hemostasis, where procoagulant, anticoagulant functions, and obviously, if the pendulum goes towards, uh, if sorry, this inherited clotting tendency happens when anticoagulants go down or procoagulant goes up. So coagulant cascade, you already know about coagulation cascade. Have you studied this in physiology?
Yes, doctor.
Students?
Yes,
Yes,
we
sir.
doctor.
So you are aware of different factors. So basically you already know intrinsic factors and extrinsic factors. So things that activate coagulation cascade. So extrinsic factor, and just brief few points I will tell you, you already know many things. Whenever there is tissue damage, the tissue will release tissue factor. That activates factor 7 and then the common pathway for factor 10. That means there is, for example, there is an injury, cut in your fingernail, bleeding started. So tissue is damaged, tissue factor is released, and that activates factor 7. Very interestingly, intrinsic factors. Okay, this is more pathological, abnormal. Surface contacts with phospholipids or intrinsic mechanisms are anyone when the, can you give a practical example when the intrinsic mechanisms are activated? Anyone? If you have studied, if you understood, this is basics. I tell you, I'm asking you intentionally. Many students don't understand this concept. Frankly speaking, can anyone tell, have you understood how intrinsic mechanism is activated? Please tell me.
It's the trauma from within the vascular system.
Like,
Exposure to collagen fibers
oh, very good. How?
by the damage to the endothelial cells.
Yes, damage to endothelial cells. Students, whoever have not understood, keep this in mind. Damage to endothelial cells lead to exposure to collagen, or best word is the subendothelial phospholipid. That is the surface contact. You know, to get these reaction, you need a platform. This platform is provided by phospholipid complex on the surfaces of the subendothelial tissue, that is we call subendothelial matrix, that gives rise to activation of intrinsic pathway. Very good. Another important fact, common day-to-day example is snake bite also, where there is intravascular coagulation happens. Intrinsic mechanism, snake bite can activate. Extrinsic is very clear, injury. Okay, if this concept is clear, I'm more concerned with intrinsic, where abnormal activation happens and all those uh, thrombotic disorders we discuss in the cardiovascular module. Keep this in mind. We discuss about procoagulant activation that lead to thrombotic disorders, but today is mainly on bleeding disorders. We talk about bleeding in the sense of anti excess bleeding because of poor coagulation. So we have common pathway, and then lastly fibrinogen is converted to fibrin. So you need to remember the names, different factors, and keep in mind vitamin K dependency is also there for these factors 7, 9, 10 too. Interesting entrance question in physiology. So more important now, practical point of view, intrinsic factors are depend on these factors: intrinsic pathway, sorry, extrinsic pathway factor 2 and tissue factor 7, and then the common pathway is factor 5, 10, 2, and lastly thrombin is formed. Thrombin is an important factor which converts thrombin into or fibrinogen into fibrin. So this is summary. Now these, if you heard of tests we do in clinical practice, we call coagulation profile testing, checking the coagulation system. We do few tests. We call one test is activated partial thromboplastin time, and if axial, it's a formation of partial thromboplastin and it signifies the intrinsic pathway. Please understand this. Activated partial thromboplastin time signifies intrinsic pathway. If activated partial thromboplastin time is increase, okay, whatever the normal, it is increase. What it means? Anyone? If activated partial thromboplastin time is increased, formation of activated partial thromboplastin is taking more time. What it means? Pavitra,
Yes, doctor.
what it means to you? Activated partial thromboplastin time is increased. If you do a test and you come to know it is increased, what it means to you? Are you getting my question?
Yep. It is to, I believe it's to measure the time taken for it to clot. It is to measure the intrinsic pathway,
Yeah. So if it is
the
increase in time,
uh, efficiency for the mechanism in the intrinsic pathway. So when it's increased, there is a decrease in efficiency of the intrinsic pathway.
very good. That means whatever factors involved in intrinsic pathway, one of them may be defective or deficient. That is making the intrinsic pathway slow or delay. Is that making sense?
Yes.
So if next time somebody said you, the patient's activated partial thromboplastin time is delayed or increased, that means there is a efficiency of intrinsic pathway is delayed. That means any factor which involves intrinsic pathway may be deficient or absent. This is how you have to correlate. Similarly, PT, prothrombin time, signifies extrinsic pathway. So any defect in the extrinsic pathway, prothrombin time is increased. Similarly, if there is common pathway, then thrombin time, formation of thrombin is common pathway. So this is, and for fibrin and fibrin, for production of fibrin, later fibrins are disintegrated by fibrinolytic system, and that can be signified by presence of fibrin and fibrin degrading products or D-dimer. So this test will define fibrinolytic system, functioning of fibrinolytic system. How much? This is quantitative. This is duration. Hope this is clear to you. Please keep this in mind because we are going to talk about this very often next. So coagulation disorder, functions of normal hemostatic process is to prevent the blood loss from intact blood vessels or to arrest the bleeding from injured blood vessels. This is very clear. So normal hemostasis basically keep the blood vessels intact and the blood in the intravascular space, prevent it going out. If there is bleeding, it will arrest bleeding immediately and restore the blood vascular function. To prevent blood loss from intact blood vessels, we already discussed about this. We need proper blood vessels, we need platelet functions, we need coagulation. So abnormal bleeding, this morning I discussed already, this is can be due to vascular disorder, platelet disorders or coagulation disorders. So coagulation disorder is one component. We have discussed already the vascular and platelet component. So coagulation disorder can be congenital, where you feel one of the any factors involved in coagulation can be deficiency or functionally abnormal. It can be acquired, can be due to vitamin K deficiency disease. Just now I shown vitamin K dependent coagulation factor. If there is no vitamin K, those factors will be not effective, especially the intrinsic pathway, extrinsic pathway and common pathway, both are there. Liver functions are important. Anyone why liver diseases affects coagulation? Anyone? Any thought?
Is it because it produces some of the factors?
Very good. So basically, if you ask me, what are coagulation factors? They are proteins. Anybody ask you where the proteins are produced? If you don't know exactly, for example, immunoglobulins, where immunoglobulins are produced? Everyone, they are proteins, but where they are produced?
The
Anyone?
liver.
Immunoglobulins,
Oh, B cells, sorry.
B cells, yeah. So B cells produce, but very good. You said liver first, because this was my point, that if you don't remember anything where the proteins are produced, you should tell liver. Liver is the site of protein production. For example, many coagulation factor, except like tissue factor. Obviously, tissue factor is produced by tissue, not by liver, but other major factors are produced by liver. So liver disorders will affect coagulation because it produces the, and if it is less producing the factors, it is lead to disturb in coagulation. Other condition, acute primary fibrinolysis, because excess fibrinolysis happen, massive transfusion of stored blood because there is less platelet and coagulation factors in them already destroyed, circulating inhibitors of coagulation. There are many inhibitors of coagulation which are normal, can be there in the blood, DIC and anticoagulant drugs. So these are the conditions where coagulation disorders can happen acquired. The most important is congenital one. We interesting to know about is hemophilia A. Many of you already know about it. The most common hereditary disorders of blood coagulation. It is due to absence or low level of factor 8. Okay, decreased functional activity of plasma factor 8 because of absence or low level. So the genes for factor 8 is located on chromosome X. That means it's an X-linked disorder, recessive type. Genes for factor 8 located on chromosome X. 33% of mutations happen de novo. We don't know why. Or de novo means somatic mutation also. It's not hereditary. So normal female, just to understand the genomics, if a normal female marry to a hemophilic male, because hemophilic male will or normal male have one X chromosome, one Y chromosome. So this is Y chromosome. But on X chromosome, there is a defective gene on a male. So when a normal female marry, what happens? So there is the combination from male to female. So two X chromosome and possible is two XY chromosome. So one X chromosome from, sorry here, one X chromosome of the father can go to daughters and one can go in combination, if you understand. So what happens is if you see the combination, if you understand, all the daughters are carrier and the sons are normal. When normal female marry a hemophilic male, and the combination goes this way. But if mother is carrier, for example, here you see these girls get married. If mother is carrier and the male is normal, that's the challenge, because it's an autosomal recessive disorder. So what happened is both the alleles should express if the disease need to express. But what happened most of the time, if mother is a carrier, the females may just have one allele lost, other is normal. So they usually, females are carriers or normal, whereas males 25%, one half of the sons or 25% males are the sufferer, 25% normal. So it's all the combination, if you understand, logical. So this is X-linked disorder, X-linked recessive disorder. Usually what you see in clinical practice, most of the time, males are the sufferer, females are the carriers. Possible is there. For example, if you see a mother is a carrier, a father is a deceased person, hemophilic, then there's one girl child can have a disease, possible combination. But most of the time, clinical practice, we see females are carriers and males are sufferers. So you can remember our, who is that in England, the Queen of England, Queen Elizabeth. She is, and her families are hemophilics. So they have this disorder. So risks includes family members of hemophilia, family history of bleeding disorders, and male sex. Male are more commonly affected than females, less likely to get females. So now, according to World Federation of Hemophilia, the severity is classified based on the percentage of normal factors in the blood, or the unit, international unit per millimeter of the whole blood per ml. So factor 8, deficiency of factor 8 leading to hemophilia. Mild if there is 5 to 40% of activity is still there, that is more than enough. Moderate 1 to 5%, less than 1% activity of factor 8 lead to severe form. We will see what happens in mild, moderate, severe based on the clinical presentation. But means how we classify based on number of amount of factor 8, either in unit or percentage. Severe hemophilia is how clinically they present. Bleeding is spontaneous, frequently into the deep tissue like muscle and joints, frequently 1 to 2 times in a week. What do you mean by severe hemophilia? The factors are less than, factor 8 is less than 1% to normal, or less than 0.01 unit, international units. So they have spontaneous bleeding in muscle and joint, which is not usually you see in platelet disorders. In moderate, spontaneous bleeding is rare. They may bleed long time after surgery, injury, or dental procedure. Frequently, they have some form of dental bleeding or once in a month. Whereas mild usually bleed as a result of surgery or major injury. Do not bleed often. May sometime you don't know they have it also when there is mild 5 to 40% activity. Clinical severity correlates with extent of factor deficiency. Yes, infant severe post-circumcision hemorrhage is very common presentations, or excessive bruising when they are active. When they are playing, they may find bleeding from joints and muscles. It's for simple injuries. Often the child presents with recurrent painful hemarthrosis, that is blood in the joints. Progressive joint damage and deformity and disability is a complication in hemarthrosis, very long-term complications, hence need to be prevented in these children. Muscle hematoma is another important. Local pressure of hematoma sometimes lead to, means spontaneous bleeding in muscles, lead to formation of hematoma, a mass that can compress the nerves or cause necrosis. That can be a secondary complication. What else clinically? They can present spontaneous hemorrhage and GI bleeding if severe, Operative and post-traumatic hemorrhage are life-threatening. Sometimes, you do a surgery without, usually we don't do the surgery without coagulation profile. Sometimes this can be gone miss, especially mild, but some doctors, because of some or other reason, past previous years, and now nobody is doing that. Whenever you send for any surgery, you do the coagulation profile, you look for PT, PTT, TT, platelet count, all those things. So sometimes, dental procedures, they don't often do the coagulation profile. In some places that may lead to profuse bleeding, dangerous bleeding sometimes. Sometimes they may have spontaneous intracranial hemorrhages more frequently than general populations. That is once again have a severe complications. Hemophilic pseudotumors may be occurs in long bone, pelvis, finger or toes because of bleeding inside the bone looks like a tumor and growing, compressing the bone, and necrosis of the bone looks like all bone tumor. Due to subperiosteal hemorrhage, bone destruction, new formation of pathological fractures in these. What is pathological fracture? Anyone? We discussed this in repair and regeneration healing lectures. So pathological fracture is fracture due to tribal injury because underlying bone diseases. Simple injuries repeated. So hemophilia A, there was other risk factors for hemophilia patients, but not now. Before 1980s, repeated infusion of blood products during early 1980s has increased risk of transmission of diseases like hepatitis B, C. That time they were not doing screening. By now we do screening for infections. AIDS was common cause of death in severe hemophilia because that time, this is all old stories. Now we have to do screening. But sometime you should be aware that AIDS has a window period, and that is sometime up to 6 months. That means in the back, the virus is inside, and ELISA test can be negative. But there are latest tests like P24 antigen test, which helps to detect soon, but sometimes ELISA is not. Thrombocytopenia from HIV infection may exaggerate bleeding disorders in HIV patients. Okay, lab test. Factor 8 deficiency, obviously in hemophilia A, lead to prolonged APTT because factor 8 is involved in intrinsic pathway. So activated partial thromboplastin time is prolonged. Factor 8 assay, when you do, you see low, depending on mild, moderate, severe. So usually immunological method shows normal von Willebrand factors, another important factors for which is both for clotting mechanism and platelet function is important. We'll see that after some time. Platelet aggregation, platelet function is normal, bleeding time, prothrombin time normal, that means extrinsic pathway is normal. So only thing you find is long APTT and factor 8 low level. So we should be aware of preventive measures. These patients should avoid situations that might cause bleeding, like sports, very like body contact sports. Should be conscious about dental care, dental procedures. When they do brush, also very careful, use milder bristles. They should avoid certain drugs that exaggerate problem like aspirin, NSAID, heparin, and warfarin, which is having bleeding tendency. And treatment of bleeding episodes should be replacement of factor 8 assay. One more important in this to keep in mind, carrier detection and antenatal or prenatal diagnosis is important to prevent the child suffering. Family history, factor 8, factor 9 levels in the carrier females. Coronary villi biopsies is another important to do DNA studies and PCR, all those things. So usually you do coronary biopsies, ultrasound guided needle aspiration, fetal blood from the umbilical veins. And then look for factor 8 assay levels in fetal blood also. These are all screening tests. Coming to the second type, similar to what you have seen hemophilia A, but incidence is 1/5 to the hemophilia, compared to hemophilia A, so hemophilia B is less common. It is also called as Christmas disease. The inheritance and clinical features of factor 8 deficiency are same as hemophilia A. Here also the gene coding for factor 9. So basically hemophilia B is factor 9 deficiency. Hemophilia A is 8, B is 9. So gene is located on X chromosome. So similar clinical presentation in term and also the genetic. A number of point mutation and detection are found. So lab findings, the difference only is clinical presentation is similar. The following tests are abnormal: APTT long, factor 9 clotting assays can be done, and which shows reduced in number or quantity. So here also bleeding time, prothrombin times are normal. That means platelet and extrinsic pathway is normal. Hemophilia B also similar. Carrier detection and antenatal diagnosis same as hemophilia A. The principle for replacement similar to hemophilia A. Some things important is bleeding episodes are treated with factor 9 concentration. So here is a hemarthrosis of the joint. So sometime we required anti-hemophilic factors, recombinant factor fusion proteins treatment is for these patients. You can see hemarthrosis, chronic, acute, and next is von Willebrand disease. Named after Finnish physician Erik von Willebrand, who first described it in 1920s. So this is a condition, absence of factors. Von Willebrand factor synthesized in endothelial cells and platelets, stored in platelet in the form of Weber pellets bodies. So deficiency of this lead to the disease. Von Willebrand factor is a carrier molecule for factor 8. So absence of Van Willebrand factor, the factor 8 function is defective. It protects factor 8 from premature destruction. So when they are attached to Van Willebrand factors, they are preserved. When they are not attached, it can be destroyed. So Van Willebrand factors also promote platelet function. So it has an additional anti-bleeding tendency. So Van Willebrand disease is inherited autosomal dominant. Hemophilia A and B is X-linked recessive, X-linked disorder. Inheritance in autosomal dominant with varying expression. There are different types. I tell you, different types of Van Willebrand factor, type 1 to type 5, 6. So there are, okay, type 1 to type 3 with 4 subtype in type 2. Most of are autosomal dominant, some are autosomal recessive and others also. So don't go very confused. Remember what simplified we are discussing here. The most common is type 1, 60 to 80% patient with autosomal dominance inheritance. Other are type 2 and type 3, depending upon which area of the gene mutations and how much the Van Willebrand factors are deficient. Quantitative, qualitative defects are seen in Van Willebrand factors based on the types. As it protects factor 8 and from premature destruction, factor 8 levels are occasionally reduced in this Van Willebrand disease. So acquired disorders where you see deficiency of Van Willebrand factors include SLE, heart diseases, some type of cancers, certain medications. So you can see here the Van Willebrand factors important for attachments of factor 8 and platelet function. As this morning we discussed about already the various other factors in the platelets complex, glycoprotein 2B3A leading to thrombocythemia. Bernal-Schwarz syndrome is the glycoprotein 1B, which is all helps in platelet functions, including platelet adhesion by glycoprotein 1B or Van Willebrand factors attachment. So clinical features, common inherited bleeding disorder, Van Willebrand disease. I tell you, there are hundreds of bleeding disorders. But we are discussing only which are very common. So you may come across some other time or some interesting rare disorders. We are not going detail in that. So this disease present with mucosal bleeding, epistaxis and menorrhagia in female, excessive blood loss from superficial cut or abrasions, operative and post-traumatic bleeding similar to the hemophilia. Hemarthrosis and muscle bleedings are rare here, except type 3, which is severe form, but very rare that also. Type 1 is more common. So what do you see in clinical practice? If you see in clinical practice, prolonged bleeding time. The test is replaced by now is PFA 100 test. So specific for this one Willebrand disease. Apart from that, you see low level of factor 8, low level of factor 1 Willebrand factors, defective platelet aggregation with ristocetin because absence of 1 Willebrand factors, which is important for platelet aggregation, just now I shown, similar to blood aggregation test. Low 1 Willebrand activity in patient plasma, APTT is normal or prolonged, just normal or prolonged. Huh? Very interesting this. They mild prolonged. If there is a 12 seconds, that may be 14 seconds, but sometimes dangerous. So sometimes we know, to know subtype, we have to do specific multi-timer analysis to know which subtype if needed, to know the severity, like type 3 is severe. Platelet count is normal except for type 2B. So treatment for the local issues like bleeding and antifibrinolytic agents are used. Most important here is desmopressin acetate, synthetic version of ADH. Stimulate the release of 1 billion factors from the cells, which also increase factor 8, high purity factor of 1. Sometimes we know nowadays a lot of these are available as recombinant DNA technology we produce in the labs, these factors, and can be given. Next is most important is acquired coagulation disorders. Acquired, just now we talk about hereditary, which has some genetic defects. Now in the lifetime, the coagulation disorders, most common then inherited disorders are acquired coagulation disorder, maybe multiple clotting factor deficiency. So vitamin K deficiency is very common, especially young children, premature children, maybe due to dietary deficiency, malabsorption, biliary obstruction, or inhibition of vitamin K by inhibitors. In clinical practice, I have seen very often in premature children's vitamin K deficiency. Liver disease cause deficiency of multiple clotting factors possible. This is also acquired thrombocytopenia, hypersplenism, or hence thrombocyte. So these are all conditions. Coming to most important, disseminated intravascular coagulation, you already know by this time. It's a systemic activation. What happens? Disseminated intravascular coagulation. Disseminated all over the blood vessels. There is coagulation. This disease is also called as consumption coagulopathy. What do you mean by consumption coagulopathy? We'll see that. So, so what happens here? Because of underlying precipitating disease conditions, there is widespread activation of blood coagulation, intrinsic pathways, extrinsic pathways. All the coagulation factors are activated without any injury, without any major need, because there is something which is activating the coagulation, some underlying disorders. We'll see which are those disorders. Systemic activation of blood coagulations leading to generation and deposition of fibrin and microvascular thrombi. Thrombi is an abnormal mass formed by collection of fibrin and platelet without any injury. It's a hemostatic plug in an abnormal condition, pathological hemostatic plug, because normally hemostatic plug should be formed at the site of injury. Without injury, we call it thrombi. We'll discuss more detail in cardiovascular week about thrombus. So once the activation of coagulation system, there is a production and deposition of fibrin, formation of microthrombi in various organ that blocks the circulation. Multi-organ failures happen here because of the thrombi, basically the clot. You should not use the word clot. It's better to use thrombi, okay, because it's an active mass. Clot is a passive mass. Clot is when you don't keep the blood external surface, it get hard. Agglutination happens. But thrombi is a mass with active components including platelet, activated platelet plug, fibrin mesh, and some RBCs in that. That will block the circulation, causing multi-organ failure. So basically, activation of coagulation system without a need, and that also systemic, disseminated all over the body, causing formation of multiple microthrombi all over the body, causing defective circulation and defective functioning of vital organs like liver, kidney, heart, causing multi-organ failure. So dearrangement, so whenever there is clot formation in the body, on one side coagulation activates clot form, but at the same time fibrinolytic system also will activate. So when the microthrombi are formed, because there is constant activation of coagulation system, the fibrinolytic system is also activated. They try to plasmin, they try to destroy these clots. So at the same time, there is some dearrangement of fibrinolytic system, which contributes to more clot formation. In some case, there is excessive fibrinolysis causing severe bleeding. And that's why it is called as, some cases, it is end up in consumption coagulopathy. What happens consumption coagulopathy? Because clot is formed, fibrinolytic system destroy the clot. So there is no coagulation system proteins left behind, and fibrinolytic systems are activated. So indirectly, they end up in deficiency of coagulation proteins and cause bleeding tendency like any other. A fulminant hemorrhagic condition with organ dysfunction and thrombotic syndrome can be seen in 5 to 10%. Very fulminant means very severe. Within 24 hours, the patient will die. That's bad. That's severe, because there is a consumption coagulopathy, hemorrhage happens, which complicated the proper treatment. If you try to give treatment also, sometimes it's very difficult. That is minor cases, 5 to 10. DAIC is not itself a specific illness. It is a complication. It is secondary to underlying disorder cause release of procoagulant factor into the circulation. So basically, or widespread endothelial damage. So DIC happens because some disease which ending up in release of procoagulant factor in the blood or endothelial damage that cause widespread activation of coagulation system, microthrombies, dysfunctions of the organ, or excess activation of fibrinolytic system leading to bleeding tendency. So acute DIC is sudden exposure to procoagulant, consumption of coagulation factors and platelet. Chronic is continuous or intermittent exposure to some amount of tissue factors. Consumption state, solid tumors. Example, this happens in solid tumors, cancers. So what are the causes? This can be one favorite question in exam. Name 6 causes for DIC, disseminated intravascular coagulation, DIC, or sometimes it's called DIVC also. That means intravascular. What are the conditions? Sepsis, complication of gram-negative infections or any infection leading to sepsis, severe infections, trauma, neurotrauma, brain injuries, road traffic accidents can lead to DIC. Organ dysfunction like pancreatitis, your pancreas start releasing its all activated enzymes in the circulation leading to DIC. Malignancies, especially myeloproliferative or lymphoproliferative, which leukemia is more prone to get DIC? Anyone? Which leukemia is more prone to get DIC? Anyone remember? No? Acute
Is it
promyelocytic.
AML?
Yeah?
Is it acute myeloid leukemia?
In that, which one? Specific type. Acute promyelocytic leukemia. Because they have a lot of granules, the eosinophilic granules that will be released in the circulation when the tumor is undergoing necrosis, cells are destroyed by spleen. Release of these granules activates the coagulation cascade and leading to DIC. Sometime you have already discussed the transfusion reaction in your seminar. Your friend told severe transfusion reaction, mismatched blood transfusion, ABO, RH incompatibility can lead to DIC. Very common in clinical practice is obstetric complication during the delivery of the baby, which includes amniotic fluid embolism. That means the amniotic fluid from the sac of the baby goes to the maternal circulation. Abruptio placentae is premature suppression of placenta, or there is hemolysis, elevated. Okay, there is a condition called HELP syndrome. You can read about it in eclampsia. So in obstetrics, endocrine and reproductive block, semester 4, you will study this. Eclampsia is pregnancy-induced hypertension with seizures. That also can lead to DIC. Retained dead fetus syndrome. Sometimes a baby die after few weeks and mother didn't notice it. It's still there inside. Sometimes they get toxic and can happen. Vascular abnormalities, blood vessel disorders, rare conditions. Sometimes large vascular aneurysms. Aneurysms are abnormal dilation of blood vessels. Hepatic failure, toxic reactions to various transplant rejection, heat stroke, hemorrhagic skins necrosis, catastrophic antiphospholipid antibody syndrome. Okay, you need to study this topic. It's a very important topic. So how the clinical presentation of DIC? These are the so they have bleeding from. These are usually most of the time nowadays in clinical practice you see is inpatient in ICUs. ICU patient having other severe complications because of the causes I explained just now. So that lead to bleeding from venipuncture sites. Just a minute. Bleeding from venipuncture sites or recent wounds, bleeding from organs, very severe. Less frequently, microthrombi may cause skin lesions, gangrene, or renal failure because of stoppage of blood supply. May end up in cerebral ischemia also. Hemiparesis, paralysis can happen. So these patients we can see. Very interestingly, you can see fragmented RBCs. DIC, one of the cause for hemolytic anemias. They may have microthrombi leading to necrosis of the peripheral tissues. This is necrodactyly, bleeding tendencies. Very interestingly, DIC lab finding, all are disturbed. Platelet count low because all platelets are used formation of thrombus. Plasma fibrinogen level low because plasmin is already used. Thrombin time prolonged. That means there is no thrombin formation is delayed. Partial activated partial thromboplastin time or prothrombin both prolonged. So basically all factors are deficient. Basically there is a lot of clot formation and all factors are deficient. So because these are all low and prolonged, but only high is fibrin degrading product because the fibrin mesh which are formed are destroyed by plasmin fibrinolytic system. So they byproduct is high, which is sometimes more specific and confirmatory is D dimer level. D dimer is also high. In fact, the best example for now in the causes you can keep is COVID-19. The good number of patients are dying is because of DIC. Because COVID-19 is activating your immune system, lot of we call cytokine storm is happening that is causing activation of coagulation and microthrombi, all those. So DIC is complication is COVID-19, remember. D dimer in serum and urine is high. That's why in COVID-19 patient, we do D dimer screening test to see whether there is activation of coagulation system and fibrinolytic system. If D dimer is high, then immediately you need to take care. They have done a lot of studies. If D dimer is beyond, there are normally is 0.5. If you understand international units of 500 micron, they talk about. So anything more than 2 is dangerous. They talk about in China, initial days, there are people with more than 10 values of D dimer. So peripheral smear will show cystozoids. Cystozoids are fragmented RBCs, polychromasia because of hemolytic, nucleate RBCs like normoblast, mark, and isonucleonucleosis seen here. So treat the underlying cause. They have to give fresh frozen plasma and for inside there are coagulation factors and platelet concentrations. DIC fresh frozen plasma must be frozen to core temperature below -30 degree within 1 hour of commencement of freezing process. So a unit of fresh frozen plasma contain all coagulation factor including labile plasma, coagulation factor 8 and 5. It usually can be stored for 12 months at -25 degree or below. Okay, just quickly about the last condition, circulating antibodies, or we call antiphospholipid antibody syndrome or lupus anticoagulant. So these are basically, this condition, you see a lot of antibodies against the factors, like factor 8 antibodies in case of hemophilic patients, because you are giving factor 8, the body is responding and producing antibodies. Factor 8 autoantibodies, the person is having self. Sometime it can be seen in postpartum females, once after delivery of the baby, cancer patient, old age, SLE, and other autoimmune disorders like lupus anticoagulants. SLE is very often associated with antiphospholipid antibodies. So basically, they show prolonged activated partial thromboplastin time, thrombosis, and recurrent miscarriage. This one, antiphospholipid antibody syndrome with lupus anticoagulant, they are triad of prolonged APTT, thrombosis, and recurrent miscarriage. So to summarize, bleeding disorder, if you see a prolonged partial thromboplastin time with normal platelet NPT, it's hemophilia A or B. Prolonged prothrombin time with normal platelet APTT, it's factor 7 deficiency, very not so common. Prolonged PTT with thrombocytopenia, low fibrinogen level, high D dimer, and fibrin products, DIC. Prolonged PT and PTT with normal platelet, liver diseases or vitamin K deficiency or during anticoagulation treatment. Prolonged bleeding time is 1 milligram factor or platelet count, or functional disorders of platelets. So this is how you need to interpret the results. That's it. Thank you very much. Any questions?